Hello, welcome and kumusta, and thank you for joining me. My name is Hao. I am your occupational therapist, and this is OT Conversations. And we will continue to talk about frames of references or models that you can use in critical care. This time around, we'll talk about the model that is called Cognitive Disabilities Model, and this originated from the Cognitive Disability Frame of Reference by Claudia Allen. The focus here originally is an approach to people with mental illness, and now it can be applied to other groups of patients where there are cognitive limitations that are observed because of an organic problem, particularly those people with brain injury or dementia. And perhaps when somebody has had to go through different processes of critical care medicine, so after surgery, for example, and they are recovering, so you can see that people at the early stages might be able to follow this model. So this model, it focuses on the residual limitations, and it emphasizes on OTs assessing patients' functional limitations. It emphasizes issuing cautions and warnings about patients' restricted capacity. And it talks about people needing to have supervision. You may need to have some kind of environmental modification as well. And this model is also talking about cognitive levels, which is graded from normal to profoundly impaired. These cognitive levels are used to describe the degree of the functional limitation of the patient. This model shared the concepts of Piaget's work on cognition, particularly on Piaget's description of the sensory motor period of development. So it borrows from that. It also borrows some concepts from neurosciences, although it disagrees or it rejects the neuroplasticity potential when you have to bring about some change in the patient. What does this mean? It just meant that for some people with severe cognitive impairment because of a severe disorder and a severe injury, then there is no neuroplasticity, or no neuroplasticity can take place because it is so big that the nerves can't perform the responsibility of the neuroplasticity. So when it comes to order, the theoretical arguments here meant that a normal function is based on the relationship of the brain, the cognition, and the task behavior. So the brain will determine the cognition, and the cognition will guide the person's behavior. It's very straightforward, isn't it? And it's very logical. Another form of order is that it concentrates on two features of cognition, and this would be the cognitive dimension of task performance and the continuum of cognitive functioning. When I say continuum, it meant that there are stages in the levels of cognitive functioning. So there is order if the cognitive dimensions of task performance, originally used as basis for describing performance across the cognitive levels, there are a few things that you need to keep an eye on. A person's attention, their ability to selectively respond to sensory cues, a person's behavior, which is their motor actions exhibited in task performance, and a person's purpose, which is a person's intended objective. Another one is a person's experience. So, what a person goes through when they are involved in a task. The process. This is the course of action followed to achieve a purpose, and the time, which is the duration over which the person sustains sensory motor associations. So there is order, but you have to keep an eye on all of these factors: the attention, the behavior, the purpose of the person, their experience, their process, and the time allowed. So you can see this, it's very complicated, isn't it? A person's not just doing one thing, but there are multiple aspects in there that you need to factor in. Now, there is order, and this model is talking about a hierarchical continuum of function and dysfunction. And this model is stating that the brain will function and will follow a 6 cognitive level. The most basic and the most primitive one is a state of coma, which is the prolonged state of unconsciousness without response to any stimuli. And this is not counted as a cognitive level because cognition is really absent. So coma is 0, so there's no cognition at all. Next one would be automatic actions, where the response is on the stimulus initiated by someone else. There are invariable reactions to stimulus, so automatic reactions. Next thing would be postural actions, and this is self-initiated, gross body movements that move the whole body into space. The next one would be manual actions, where the person can start using their hands and occasionally other parts of their body to manipulate objects. The next one would be goal-directed actions, whereby the person has series of steps that match a sample or standard of finished product. So with a goal-directed action, if you're making crafts, you show them an item and they'll be able to follow the step-by-step guidance on that one. So that's a goal-directed action. The next one would be exploratory action, where the person can discover how changes in neuromuscular control produce different effects on objects. And the last one would be planned actions, where the person will estimate the effect of actions on objects that are present, and they anticipate secondary effects as well. So really, you have an insight, you have a foresight. Okay, so in critical care after the operation, the person, or during the operation, or after the operation, immediately after, they're still highly sedated, so they are on coma stage. And then all of a sudden they'll start moving. Once you stop the sedation, they're on automatic reactions. And then they start to move, gross body movements that follow instructions just for comfort, postural reactions. Then a point where they can start engaging with occupational therapy is at the stage of manual action. So they can do little things. And at best, if they are there, because they're limited by a lot of other connections, then they can do goal-directed actions. This is where you can show them crafts, finished products, and they can start doing things. And for those who are in critical care because they just needed to wait, for example, they're there because of needing to have a filter, a dialysis machine, for example, or VADs, they are capable. They have the mental ability to perform the tasks, but then they cannot do those tasks because they are limited by the situation. So they can do planned actions only. It's the context that's limiting them. This model then talks about a problem. How's there going to be a problem? If the brain abnormality underlies the deficit in cognition, and it's producing restrictions in task performance, and that the cognitive levels describe the extent of cognitive disability and the degree of functional limitation. There is a problem if there is an organic reason. That's why cognitive behavioral frame of reference, it is popular nowadays. CBT, yes, it's good. But when somebody has an impairment, an organic reason, when there's organic reason for the brain problem, then you use cognitive disability approach. All right? How do we do our intervention? Here, really, occupational therapy does not change the cognitive levels. We cannot do much about the cognition if there are limitations. So you cannot do so much. And you can't change the person anymore at the end of the day, because the disorders will place restrictions on learning, particularly for those people who've been affected by stroke, for example. They were influenced so much by the stroke, there's so much brain pathology, you cannot change it. The approach to intervention will emphasize on measuring and monitoring the changes in cognitive level. So your role as a clinician will be to monitor this cognitive level. You can provide as much stimulation as you can, but you want to guide them through from one level to the next. Yeah. So you can measure that and you can monitor the changes. And the intervention will emphasize on adapting the intervention to fit the level in which the patient is functioning. For example, if they are in critical care and they're on the postural stage or gross motor, then that's what you can do. You can't start reorientating them. Yeah. Okay, so there, in here, what's nice is that there is an element of engagement. There is an element of participation. So while therapy can offer opportunity to process information at a higher level for a brief period only, though, patients should not be pushed to struggle at a higher function. So what's nice about this is that it's taking into account the humanistic side of things. You can't, for somebody, say, with learning disability, you can't push them beyond the level that they are capable of. And here, the treatment are divided into 4 phases. And what are these? On the acute phase, where the therapist will evaluate the cognitive level. You can do this by pure observation alone. If you know the levels, you can just do that observation. And then that's the first phase of treatment. The post-acute phase would here where patients can engage in activities and the therapist can monitor the cognitive level and can recommend how much assistance a person will need at discharge. The next stage would be the rehabilitation phase. And here, what the aim is to improve the patient's performance by providing adaptive equipment, modifying the environment, teaching caregivers to provide assistance, provide activities at an appropriate level to the patient, and avoiding or supervising activities beyond the patient's ability. Okay, so in rehabilitation, you encourage, you do more and more. Okay. And then the last one would be long-term care, where we should be providing community-based activity program for people, particularly performing at level 3 and 4. And that would be the manual actions and goal-directed actions. Yeah. So for critical care, the part here that is significant to us is the acute phase, particularly once they are getting off the sedation, and then the post-acute phase. So you can wait on that stage. But as soon as they're medically optimized and they are critically or they're stable, yeah, then they're suitable to leave critical care, then you carry on their activity and you will now, in the wards, you'll go on the post-acute phase or even rehabilitation phase. Here, the main approach to intervention part is mainly going to be environmental compensation. Yeah, compensatory strategies where you need to make adjustments to the residual effects of the disease rather than addressing the disease process itself. Okay, so it just ties up with the frame of reference called ecology of human performance. So, what would be the objectives and the goals? Here, the goals would be giving the patients the task that they can do. The next thing is you enable the patient to comprehend and accept permanent limitations. This will go particularly on the long-term phase. And then you want patients to identify the least restrictive environment in which the person can function safely. And here you provide caregivers with the information about disabled persons' limitations, and you teach them about some necessary supports, particularly with their function. And some of the terms of this model, or some of the things that you will be talking about when you're using this approach and when you're using this in your treatment, you'd be using terminology such as attention, which is a person's selected responsiveness to sensory cues. You'd be talking about behavior. You'd talk about cognitive capacity, right? So it's not capacity to make their decisions, but for us, the language would be cognitive capacity. And by this, it means the potential for mental processing, yeah? Or you can talk about cognitive dimensions of task performance. And these are the observable aspects of mental activity, which will include their behavior, their process, their time on how they spend and how they deal with situations, their experience about the situation, and attention. So you're talking about cognitive disability. You're talking about cognitive levels. You are talking about cognitive limitations. Yeah? And the cognitive limitations, these are deficits in mental processing that can be observed during a task performance. And you will be talking about environmental compensation, experience. You'll talk about process, in which case it means the course of action that is followed to achieve a purpose. So patient's process is doing this and that process. That's terminology. Purpose, you can have symbolic cues, and these are information that are conveyed through symbols. So you can use these terminologies. You can use a terminology such as task analysis, or time, or voluntary motor action. And this is a behavioral response to a sensory cue that is guided by the mind. All right? Okay, there you go, guys. This is one model that you can use in critical care. Once again, it's called Cognitive Disability Model. I hope you learned a little something today. Until next time, bye.